Good morning, Mac. Great to see
Good
you.
morning, Pam. Good to see you, dear.
You ready to get started today?
I'm ready. I'm ready. Let's go. Let's open up. Let's get it.
Let's open up. I love it. Let's talk. Let's tell our listeners what we're going to be talking about today. We're going to call this episode the Trifecta Pathway to TMJ Pain. Mac,
Yes.
why don't you?
Trifecta, big word.
Right.
Comes in threes. It comes in threes.
So tell us about that. What do we mean when we talk about the trifecta of pain, TMJ pain?
Well, first of all, I must say that the most confusing thing about TMD is people can have certain bites, not be in pain. Other people can have basically the same, quote, bad bite, for lack of a better word, and have severe TMD pain. And when I have a pain patient and I hear their story, we go through the interview, and then it comes time for examining the mouth. There's three things that I'll look for, three things of the way that the teeth don't come together correctly. One is called posterior interferences, which we're going to discuss in detail in another podcast. But the teeth are, quote, interfering with each other.
Mhm.
The second is a tarched mandible, which again we're going to cover in another episode. And a tarched mandible is no different than a tarched hip because things are not balanced. And we talked about it in one podcast where you can do a self-evaluation by putting your fingers, two index fingers or a V of fingers across the tops of your bottom teeth and lightly close down. And if one finger touches and the other finger doesn't, you have a tarched mandible, much like one leg being shorter than the other. But the third is a deficient maxilla, which you've already explained on craniofacial development, that because of certain reasons, the tongue, whatever it might be, doesn't mold the bottom third of the mouth. And so the upper and lower jaw, mainly the upper jaw, is deficient, meaning it didn't grow to its full potential. And
Mhm.
because of that, now the bottom teeth don't fit. It is very difficult for a dentist who's been trained in the teeth, the jaws just hit, to be trained in the fact that the upper jaw did not grow to its full potential. They can't see it.
Mhm.
And 20 years ago, I was introduced to this concept, which opened my whole entire eyes to neuromuscular dentistry and the fact that I was missing one third of the problems that my TMD patients have. So I'd like for you to, you've already touched upon deficient development of the bottom one third of the face in children. So you want to do a little recap, and then we can get into how you diagnose and how you treat, quote, the deficient maxilla, and let the audience know how they can somewhat self-diagnose themselves.
Absolutely. I want our audience to think not just for themselves, but if you have children, make sure you're thinking about your kids too. But it all begins with the airway. Okay. If as humans, we're supposed to be obligate nasal breathers, meaning we're supposed to be nose breathers, right? And the only time we don't breathe through our nose is supposed to be when we're sick, meaning, our turbinates or the things that filter the things in our nose, like the sponges, they're clogged up, whether you're sick or it's from environmental allergens. But for whatever reason, whether it's a deviated septum, the cartilage in the middle of the nose, if it's crooked, congested turbinates, or the adenoid tissue, which is like the spongy tissue in the back of the nasal cavity. If we can't breathe properly through our nose, we will compensate and open our mouth to breathe. If you think of it this way, we can go without water for a little bit, we can go without food for a little bit longer, but we can't go but a couple of minutes without air. So our body will compensate everything for the ability to breathe correctly. And so if our nose is plugged up, we become these mouth breathers. Now, how does that affect the face? Remember, if we're mouth breathing, we've got to drop that tongue down so that we can get the air through the oral cavity. So we develop a low tongue posture. And when the tongue is down low, meaning it doesn't sit up against the palate. That tongue is a strong muscle. It needs to press up against the palate like it is a blanket that sits across the entire palate when we're breathing. As a matter of fact, I want our listeners right now to kind of pause. And if you're driving, don't close your eyes. But if you can, just close your eyes for a moment and open your mouth and make sure your tongue is down and just take a deep breath in. Okay. Now, put your tongue all the way up to your palate and see if you can breathe. No, it's impossible. So if we want to open up that airway, we have to open up the mouth and drop our tongue down. Now, when the tongue sits low, our cheek muscles and our lip muscles will start to squish our face in. And instead of the upper teeth coming into this nice broad U-shaped skull, our skull gets actually very narrow because our tongue is an antagonistic muscle. It fights our cheek muscles. And if the tongue's down low, the cheeks squish our face in. So our upper face, the middle part of our face, part that's right behind your upper lip, starts to squish in. And then the teeth look what? Crooked, right? Because we don't have this U shape to get more space for our teeth. It's narrow and it come in crooked. And then if our upper teeth are narrow and crooked, the lower teeth that fits into the upper teeth, right? We bite down, our lower and upper teeth meet, that jaw gets even more narrow. So we start having even more difficulty time breathing through our mouth, and our mouth opens more. As we continue to get older, we develop this really bad, poor resting oral posture. And so that kind of just exacerbates that full face issues, poor jaw development issues. Um, but that's how it all begins. It's just improper airway development or congestion that creates this poor resting oral posture, and everything just gets crooked and crammed in. And Mac, you always give this great analogy to me because you're such an amazing communicator. You're always like, Pam, when I talk to my patients, I always tell them it's like the upper jaw, that mid face, we call it, it's like the garage, and the lower jaw is like the truck. You've got to have enough space for the truck to fit into that garage. Otherwise, nothing's working and things start to spin out of control.
Yeah, and so I think I told you this country analogy before, but I'm going to build me a new waiting room for my patients, and I'd calculate it to be 10 by 10, and all the chairs fit perfectly against the wall. They're just as straight as they can be. I mean, the design is perfect. But the carpenters didn't read 10 by 10, they wrote 9 by 9, and so they made the waiting room 9 by 9. Now, what happens to the chairs? They're no longer in a straight line, they're jumbled up.
Mhm.
So, when genetics says that the palate should be this big and the teeth should be just big enough to fit within the upper jaw, but it doesn't develop, then the teeth have to come in crooked. So,
Right.
where I'm leading with this is that if you do have, the listeners have a deficient maxilla, what are some of the things they can look for in their own mouth? Well, crooked teeth is one. And you've already mentioned in a previous podcast that a V shaped, V like this instead of U shaped, and that goes both ways. It goes laterally and it goes up and down. So it goes parallel to the floor and also up and down. The vault, the roof of your mouth should be like a V, I mean, like a U and not a V. And where your teeth are should be like a U, nice and rounded and beautiful and not like a V. There's other things like anterior wear. Do you have wear in your front teeth? Well, why? Well, it's because the lower jaw wants to close in such a way, but the upper jaw is too short. So
Mhm.
when the lower jaw closes, it hits these front teeth. It's a more comfortable position. So, what other symptoms or signs do you believe that the listener should know about having a deficient maxilla? Of course, now we're going to bring in the joint because the joint's a big, big issue in a deficient maxilla.
Well, before we get into that, let's make it a little simpler, okay? Whether you're looking at your child or yourself, let's talk about the kids for a second. As a parent, after our kids are no longer infants, we're trying to get our sleep wherever we can. So we don't check in on them very often at night. but start watching your kids a little differently. If you find that when they're on a screen or when they're gaming, their mouth is open, like the lips are not together, that is an immediate sign that there is poor resting oral posture. There can be an airway issue. And at that point, I do want you to go check on them at nighttime when they sleep. Pick a random 3 nights out of the week and just go in and check on them. If their mouth is open when they're sleeping, if they are snoring at all, if they are all over the bed, like they're restless sleepers. Any child that's past the age of 2 that's still bedwetting, night terrors. There's all of these are usually some type of sleep disorder, breathing issue that's related to the whole mid-face issue we're talking about, that mid-face deficiency. So that's when we look at that's how you look at the kids in yourself and in your children. If you have something we call venous pooling, meaning dark rings under your eyes, if your kids have chapped lips or you have chapped lips all the time, there is a underlying breathing issue. Hence, you probably have a mid-face issue. And then just like you're about to talk about, Mac, the mid-face, again, holds our lower face, which has that TM joint, that joint that's, if you put your fingers right in front of your ears, you feel that ball, right? If you're having clicking and popping when you open that joint, or your jaw has to wiggle, go side to side to open, or you can't get those 3 fingers in, like we discussed in a previous podcast. If you stack up your 3 fingers vertically and you just, slide them between your upper and lower teeth, you should be able to open that wide. It's like about 40 millimeters is the bare minimum you should be able to open. So those are like quick do-it-yourself examinations. But where it can get a little bit dicey is that the way you and I have treated patients, I treat children and adults, you've treated adults, is we don't just look at straight teeth. But like you said, crooked teeth are the easiest things we can see. Everybody can identify crooked teeth or crowded teeth. But a lot of times people can have perfectly straight teeth and they can have a retruded jaw, meaning like their jaw is set back and still have issues, but no one's diagnosing them correctly because unless they have a 3D scanner, which is called a CBCT, they can't see the airway unless they're getting a sleep study. They don't know if they have an issue. So this problem goes undiagnosed, and kids are coined as having ADHD, or adults just think that their chronic fatigue and headaches is just something else, but it could just be airway and TMJ, right?
Right, right. So you're talking about a jaw, a lower jaw that goes backwards, is compressed.
Mhm,
So when the jaw goes back, the 2 condyles go back.
mhm.
Because remember, the jaw is one bone with 2 joints on it, and one can't move without the other. So as the jaw goes back, not only do the teeth not fit correctly, they stress each other, but it also compresses the joint, which causes the joint to change shape. It causes it to click. It causes it to make noise. It
Yeah,
causes deviation of the jaw when opening and closing. And sometimes it causes severe pain. In my experience, that's all due to a deficient maxilla. There's
yes.
no reason, and we know that it's deficient because we can track the jaw. We watch the jaw as it closes, and it's closing in a certain arc that's nice and smooth, and all of a sudden it reverses and it takes a backward movement
Mhm.
just right there on the computer. And so that backward movement takes those joints back up too far back up into the joint, which causes all these problems. So I think that in my personal opinion, the vast amount of joints issues are due to a deficient maxilla, which is due to incorrect cranial facial development, which all dentists should be monitoring, and all dentists should have somebody that they can send these kids to that know what you know.
Agree. For me, Mac, Um, I wish we had really well-trained lactation consultants because not everybody's different. Not everyone has the same training, but the babies should be looked at, their tongues should be looked at, their airways should be looked at. And if the babies are struggling with breastfeeding, we know that there's a possible tongue tie issue. And these things are not, a lot of people don't know how to look at that correctly. Um, but again, it's just about getting that tongue to the right place and clearing out the airway. And if there's a tongue tie, to release that so that that mid face can develop correctly. You always give this analogy of like the lower jaw, the mandible being like porch swing. And I do love that because, if, I always tell people like your mandible is not fused to your skull. It's not fused to the cranial base. It's held there by muscles and ligaments. So essentially, it is just a swing. And that swing stops in space, like your jaw stops in space when you put your teeth together. That's the hard stop. But that doesn't mean it's a healthy stop for the joint. That joint can be, like you said, up and compressed back into the skull, causing that arthritis, causing the TMJ. And you can, again, have perfectly straight teeth because you went to a doctor that straightened them out for you, but it doesn't mean it's physiologically balanced for your for
Absolutely.
your airway.
Absolutely. So we're going to use the swing analogy a lot because it has different uses. So in other podcasts, you mentioned a closed bite, meaning that the lower jaw fits inside the upper jaw and is, quote, locked in. Well, if you have a porch swing and it's 6 inches off the ground, that's not a very good, very comfortable porch swing to sit in. And it's because everything is overclosed. It's not in a proper space. It's not where it's supposed to be. So, yeah, but and then if you just to talk briefly about treatment, because everybody want to know about treatment, if you put in a plastic orthotic that opens the bite where it's not locked in, you give freedom of this lower jaw, and freedom of the lower jaw is absolutely imperative. And there's one thing that my dentist dad taught me about everything in dentistry. If you take away the offending agent that's causing a problem, let's say gum disease, and you take away the bacteria that causes the gum disease and teach the patient to keep it off, the body's going to heal itself.
Mhm.
If you take away the obstruction of a correct bite using the orthotics that we use, you're going to take away the offending agents of the trifecta, and the body is going to, quote, get better and heal itself.
Can I interrupt you for a second? Because a lot of people don't know what an orthotic is. Our listeners don't know what that means. And an orthotic is something we typically use on older adolescents and adults. And it is an appliance, it's a clear appliance you wear on your lower teeth that puts the joint in the right place and puts the muscles where they're physiologically balanced so they're comfortable, they're not strained in any way. And that appliance is worn either at night or all of the time to make sure that we can get that jaw working properly. We get rid of the clicks, the pops, the pain, the headaches, etc. Now, if you notice, it's not technically correcting anything because, while that appliance is in your mouth, it's going to be working great. But the minute it goes out, then your teeth go together and that jaw goes up and back and the pain starts again or the noise starts again. So we use orthotic treatment as a diagnostic tool to see if, okay, because a lot of the pain issues, this is in pain patients, they can be other things. So we want to see if it's TMJ related or not. And then once we have that orthotic made and we make it to where the muscles are comfortable using electromyography and we make it to using a CBCT to check the joint space and make sure that's balanced. And that, I mean, it's not an arbitrary night guard. Night guards are not for TMJ. They will help once in a blue moon, but they're for grinding teeth and they're not for TMJ treatment. But once we get the orthotic and the patient's comfortable, and as well as I know, they know in a month, maybe sometimes even a week, if that's the right treatment modality for them, we have to talk about how do we get the face there now and the teeth there? Is it braces? Is it surgery? Because not everybody wants to live with an orthotic indefinitely. And so, one other thing I want to touch upon is like Invisalign or aligner treatment. Is that good for TMJ? It can be, but again, you've got to be diagnosed correctly. And if it's this true skeletal issue, Invisalign and aligners are awesome product to move teeth. I always tell my patients I love to use it if we're just talking about straight teeth, but if we're talking about TMJ, it's going to be more involved in that. And We would talk about the other orthodontic options. I'm not big into surgery. Seldomly have I found the need for it. Definitely not joint replacement surgery. There's very few people in the country that can do it well and successfully. And successfully means like half the time it needs to be redone or it's ineffective. Um, but you know, it needs to be diagnosed correctly, and then you get into different modalities of treatment, which we'll talk about in further podcasts. But you can, I want to emphasize, you can have straight teeth, but still have a mid-face deficiency. You have to have the proper tools and training to be able to identify that.
Yeah, and you can have one, two, or three of the trifecta. You can have only one that causes pain, two that causes pain, and you can have all three that causes pain. And then other people can have all three and not have pain.
Right.
So the dentist that's treating you has to understand all of this and has to spend time with you. So this is extremely important. I can't overemphasize too that the relationship that you have with your treating dentist for pain is extremely, extremely important.
So true.
So maybe one podcast we can talk about the different appliances because I've done them all in
Ooh,
my
like
career.
that. Write that down.
Yeah, so because people don't understand, they call it, well, I've had a splint. I got a drawer full of splints.
Oh my
Well,
goodness.
it's because they're not precision made.
Mhm.
They're not taking into account the porch swing or the torqued mandible. They're not taking all these things into account. They're just putting a piece of plastic, a POP,
Right.
in between the teeth.
That's all they were trained on. That's what we're trained on. So, I hope that today we did a good job on opening up the way we look at people's faces again. And I hope that we open up the way you're looking at your own faces and your children's faces, and you understand the development of the midface and how it relates to the lower part, which we'll get into next time about that torque mandible, right, Mac?
Yes, and so in my opinion, when it looks right, this face, guess what? It's right.
That's right. All right, everyone.
It's gotta be simple. If we overthink this, then it's just you're overthinking it too much. It's gotta look right and gotta feel right, period.
Exactly. All right, everyone. Until next time.
Next time, see you later, Pam.